Good morning, everyone. Welcome to TeleShadowing. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Burgess. Dr. Burgess is serving as the Acting Deputy Secretary of the Maryland Department of Health's Behavioral Health Administration. She is responsible for Maryland's public health behavioral system, serving over 300,000 individuals with direct oversight of administrative and service budget of over $400 million, in addition to a clinical oversight in the Medicaid budget. Dr. Burgess also serves as a Chief Medical Officer and Director of Quality Integrated Care Management for Maryland Health Financing and Medicaid within the Maryland Health Department. Dr. Burgess completed her medical education and a postgraduate research fellowship with the University of Kentucky. She also completed a general psychiatric residency through Virginia Commonwealth University and a child and adolescent psychiatry fellowship with Johns Hopkins University. She is board certified in general psychiatry and child and adolescent psychiatry, as well as healthcare quality and management with subspecialties as a physician advisor and managed care by the American Board of Quality Assurance and Utilization Review Physicians. Dr. Burgess has served the state of Maryland since 2012, first working in the Medicaid pharmacy program until 2016, before moving into her role as Chief Medical Officer. Dr. Burgess advocates consistently for the collaboration and coordination of Maryland Department of Health with its partners and stakeholders to support the vision, which is lifelong health and wellness for all Marylanders in the state. And now it is my honor to request Dr. Burgess to begin today's session. Thank you.
Thank you, Michael. That was very kind of you. So I'm going to start by telling that I'm at Johns Hopkins, and the internet connection at like many universities is in and out. So I'm hoping that it'll hold up for us. I will start sharing my screen if I could. Really want to thank everyone for coming today. I know that it's a Saturday, so I really appreciate it. I want to basically take you through my journey from the time that I started school and just give you a little taste of what I've had to come up with as the CMO. And then I will give you a couple questions just to give you a feel for what I do. And if you have any questions afterwards, please feel free to ask me. As Melanie has said, I am a Chief Medical Officer Medicaid, and I'm also the Deputy Secretary Interim for the Behavioral Health Administration, and I can describe to you what that is later. So just to start with my road to working in the public healthcare system, actually, I didn't start thinking that I would work for the government. I was going to be a clinician, and I was going to see my patients, and I was going to do this for as long as I could. I started my journey in Tennessee, where I went to high school. As many of you know by now, you want to work really hard, as I did. I love school. I then went to another state called Kentucky, and I was an out-of-state student. For those of you who know anything about the United States system, when you go to school out of state, it's pretty expensive, but the University of Kentucky was very good to me, and they gave me a scholarship, and I was very grateful. And I spent time there not only in medical school, but I stayed another year to do a research fellowship. I'm not the only one that will stay an extra year to do a research fellowship. I was told by my mentor that a research fellowship can make you more competitive, and I wanted to be competitive. I wanted to go into a field that I wanted to, not because I felt like I didn't have any choice. So my research fellowship was a mixture of surgery, internal medicine, and psychiatry. I had the opportunity to see all three specialties, and I chose psychiatry as my specialty. By that time, I decided to move to Virginia, and I did my internship there. By this time, I had a pretty good thought that I'd want to go into child psychiatry specifically. And so I was very fortunate to have a wonderful doctor that interviewed me. And I told him that I knew I wanted to go into child. At that time in the United States, if you were going to go into child psychiatry, you still had to do your general medicine rotations in adult medicine. I made my case for why I should do it in pediatrics. And I was the first one to ever do pediatric internship at the Medical College of Virginia. And since then they've seen the logic in that. I went on and did my residency there. And if you want to in child psychiatry, you only have to do 3 years in psychiatry. Usually, if you do adult general psychiatry, you have to do the entire 4 years. I chose to leave after 3, and I went to my fellowship in child and adolescent psychiatry in Maryland. And yes, it was at Johns Hopkins. And then I started to attend. And as you may know already, the attending position is what occurs after your residency, and for some who stay and are chosen for chief residents. I then went to private practice, and I worked not only in private practice, but outpatient mental health centers. For me, I found that doing a mixture worked best. And I really think that both populations benefited from my working in both environments. And then I'll tell you about what this journey has taught me. And so the next several slides are just pictures of these various locations in the United States. So this is Clarksville High School. That's where I went to school. I've seen other speakers do this, and it's amazing. You do, when you get older, you'll understand. You do feel this warm feeling inside. Wonderful teachers who mentored you. You see that on the left and the right of the middle, you have these round areas. Well, I wanted to be in school so much that I stopped some of my sports. I don't recommend it. I think it's great if you can do both. And I would run around with the track team so I can stay in shape. I do think that being physically active is very important. I think that eating well is very important. It really helps you to maintain your energy, as some of you probably already know. This is where I went to undergraduate. It's called Murray State University in Kentucky. And I'm very interesting. I not only love sciences, but I also love horses. And in my family, we raised horses. My grandfather did. And so on the left, you have the campus. You won't be surprised, that's where I've spent most of my time in the library. And the middle of the slide is Blackburn Science Building. So I had a wonderful, wonderful chemistry teacher, Dr. Clark, and he would open the building for me on Saturdays because I love to go in and do my experiments by myself. We are a competitive bunch, but I don't like competing against people. I like competing with myself, and I like competing with people, but not against. And sometimes we can be a bit aggressive. So he was very kind. He knew I liked making good grades, and he let me do that. So to the right, I did take my equine classes, which I loved, and I really encourage you to fight for keeping your hobbies. After university, I went to the University of Kentucky for medical school, as I said before. So if you look in the middle of the screen, you see the University of Kentucky, and just a little bit to your upper left, that's the medical center, Albert Chandler Hospital. And I, being as logical as possible, try, and most of us did really. We stayed as close to the medical school as close as we could, actually. And so my apartment was just a little bit below Waller Avenue. And so I walked to school, and I stayed there a lot, as we all did. And so after the University of Kentucky, as I said before, I went to the Medical College of Virginia. So below the VCU, you see the MCV campus. It's since changed its name. And the VCU Medical Center is in Richmond, Virginia. I really, I found that I've really been supported in my education. I don't know if I could ask for more. This is where they allowed me to do something they hadn't done before. And you know, when you can have people who support you that way, it's something that you take with you. And I hope that I encourage young people to do the same when they're with me. Sometimes we older people can get a bit stuck in the mud, but we really look forward to young people encouraging us to see things differently and do things differently. And so this is a picture of Johns Hopkins. That's where I am located currently, so it's really loud. I apologize, but you know, they have helicopters coming in and out. To the right is the old building. I love old buildings. And when I was at Hopkins, my husband was in New York. I loved going there on the train because I do love old buildings. But you know, things change, and they can change for the better. And so on your left is the new buildings. And Hopkins too is an institution that has really treated me well. They also showed me about, you know, initiating something new. And so when I was at Hopkins, I asked if I could do actually a parallel training in family. And my professor said, as long as you don't be late for your work, as long as you don't how does it, let me say it another way. I want to say it in a positive way. He said, as long as you keep up your work, as long as you get as much as you can from your child fellowship, you can do it. And I want to say it that way because I do think that thinking positively allows your professors to see that you are willing to try things that are different, and not just because you want to get out of things, but because you really do want to learn more. After my fellowship, I decided to stay in the city and work. I worked at an institution called the Kennedy Krieger Institute, and that's a healthcare center which looks after children who are fragile. They're medically fragile, they're neurologically fragile, they're psychiatrically fragile. Again, I had wonderful teachers who really spent a lot of time. I wasn't attending at that time, but you still, I felt, could benefit from having mentors. At this time, I was also an instructor at Johns Hopkins University, and quite frankly, my task was to bring in speakers who were in different fields of medicine. So it's very ironic that I'm doing this today. So on the left, you have the Inner Harbor. I think it's quite beautiful, and I love going down there and walking and running. On the right, because I do want to be transparent, is another part of Baltimore. It's a part that, and I'll talk about this later, you know, that has individuals who struggle with life, and some would say are disadvantaged, and I'll talk more about that as I get into the presentation. I spent about 3 years in Baltimore, and I talked to one of my mentors, and I said, I really want to be the most excellent physician I can be. What do you recommend? And she said, I recommend you go to the rural parts of Maryland and be the only doctor. And you need to learn how to be innovative when you don't have everything around you. If you know anything about cities that have all these universities, you know that you have your resources and you have other colleagues. And so when I went to my first area in Maryland, it's called the Eastern Shore, you know, it's amazing because if you're not careful, people can dissuade you from doing something that could be one of the best things in your life. And I was told horrible things about it being different from the city. I'm just so grateful that I went anyway. I'm even embarrassed to tell you things that people told me. And I don't think that they meant to be mean, and I don't think they meant to be hateful. I just think that when you're not exposed, you can have fears, and sometimes those fears are unfounded. I'm not saying sometimes they're not, you know, with merit, but sometimes you can find out that you may have a better experience than what you ever thought, and I did. This area of Maryland is on the water, as you can see. And if you know, well, you may not know, so I'll tell you. Maryland is known for our crabs. Some people do not like that type of food, but we're known for that. So I stayed on what we call the Eastern Shore for 2.5 years. My husband is an anesthesiologist. And at that time in medicine, the hospitals would hire teams. And when another team came in and they gave a lower bid to the hospital, that team would have to move. So the next area that we went to, and it fit what I wanted to do anyway, was Southern Maryland. And Southern Maryland is a green. It's a bit different than Eastern Shore, but as you can see, well, this is not really good rendition, but so I will tell you, but St. Mary's County actually is on the water. I love the water. When I mentioned my hometown, I did not mention that it's on the river. So I'm a water person. I stayed here for 2.5 years, and again had to move. And so the rural parts of Maryland, positives and negatives. The positive part is the rural parts of Maryland, as can be said of some other areas in the United States, is what we call a low service area, right? And so if you go to those areas, your medical school costs will be paid. I, was fortunate, but for those people who have a lot of medical school costs, they'll be paid. The trade-off is that you'd have to stay in the area for a certain amount of time. The other positive that I think I experienced working in the rural parts is that, it allowed you to help those with less access to care. I don't know if I can express to you how warm people were to me, how kind people were, as opposed to what other people would say about going to the rural parts of Maryland. But they really do have a warm spot in my heart. But there are challenges. There are fewer healthcare resources. So my mentor was absolutely correct. I did find that to be true. But even with that challenge, there were positives. Because there were so few of us in the areas, we really became very close. The pediatricians, the child psychiatrists, we worked closely together. They understood that I couldn't see all the children. So sometimes I would see the children when they were really having a hard time. As they stabilized, the pediatrician would see them. And when they needed me again, I would see them again. I would go to the ED, emergency department. If somebody called me, they knew my cell number, and I would show up whether or not I was on call. We really just pitched in. And of course, then I'm young and we're excited. And so it was really nothing but, for me, positive. However, the challenge of having fewer health resources, it does come with a price. Sometimes, if you're not careful, you really just spend your time seeing patients, and you don't get away, and you forget to go and receive nourishment. the outcome of that is sometimes you aren't really paying attention to the most current information. And sometimes what I found happened in my experience was you did have clinicians who unfortunately started relying more on medications than seeing a patient as an entire individual, the family and the child and the school. And I started to have actually competitors, employees refer patients to me. And I was, again, because I'm fortunate, and I had, you know, excellent training and professors, and I would figure out a way to go get educated. But I thought, after a while, I'm only one person, what can I do? And it really saddened me. I thought to myself, someone needs to do something, set up a policy, a guidance to help people know what to do for the children that are coming into the office. Well, some of you may have heard this saying, be careful what you wish for. I was on vacation with my husband one day, and I went downstairs. I have a friend of mine, and she says, regarding jobs, she says, you always look, Lisa, you always look. And so I said, okay. And so I was looking at really just perusing the internet, and I saw this advertisement that said, we're looking for somebody to lead a program reviewing antipsychotics for youth. And I said, wow. I had a choice. I could either stay with doing what I loved, seeing patients, or I could say, you asked for this, what are you going to do now? And so I said to myself, never, ever give up. So this is what I wanted. And I talked to many, many people, as I'm sure some of you do. And they said, well, let me be frank with you. Some were not supportive. Some were not. Why? You haven't done this before. You're a clinician. You'll have to deny medications, and you want to say yes, the patient can have what the doctor thinks they need. And yet I did have other people that said you should do it. At the end of the day, I had to go back and say, you know what, I'm going to jump. And I did. And I'm so grateful that I did. So I'm going to, my job was to lead the implementation of the program. It's called the peer review program. And my job was to review antipsychotic medications prescribed for youth in Medicaid. The program really, and I have to give credit to all of the doctors and the pharmacists who thought of this program, who designed it before I even came on the scene. And I came on the scene in 2012. And it took a lot of input, not only from the pharmacists and the physicians and the nurses, but also from families saying what they needed. So the design was that every antipsychotic prescription written for a child would be reviewed, every single one. And it would first be reviewed by a pharmacist, and they had the criteria. And if the pharmacist was concerned, based on the criteria, that it should be denied, and the prescriber disagreed, it would go to a University of Maryland. That's our state university here in Maryland, a medical school, physician. And if the prescriber still disagreed, it would come to me. Sometimes the resolution was very easy because it was an issue of communication, misinterpretation, and sometimes it took me visiting offices. I will say that that experience really humbled me. It allowed me to understand that sometimes you think you understand what's going on, but until you can really sit down and talk to someone, you may not truly understand the entire picture. Because sometimes what happened was actually the physician needed assistance. Yes, there's a lot of resources that we have, but unfortunately in behavioral health, I would say we could probably do better with accessing and providing resources for our constituents, our population. And so sometimes because I was in the system, I was able to work with the provider and find what they really needed all along. The benefit of my being here was, if you remember my moving about every 2.5 years with my husband, well, that allowed me to have been in basically all parts of Maryland. And so when I would have a prescriber that was on the Eastern Shore or Southern Maryland, and they would say, you don't understand what it's like, I could say, I really do. And because, again, remember that if you remember what I told you, there are not a lot of people on in the rural parts of Maryland, and so we pretty much knew each other. And if we didn't know each other, we heard of each other. And so sometimes what I was taught and what I learned was that, and this is not every situation, but sometimes what you see as a negative, and I didn't at that time, but there were people around me who saw my moving around a negative. But sometimes what you see as a negative could really end up working out for you. So that was my road to what I call the medical advisor for Medicaid. So after I spent time as a medical advisor in Medicaid, I realized, if you see the very first line, government staffing, it's not uncommon, you may have heard this too, that there are not a lot of people sometimes employed. And so it's not uncommon that that a person will come and they'll do one thing, employed for one position, and then end up doing another. And that happened to me. But I knew that, to be quite frank with you, and I was looking forward to it. So although I was a Medicaid medical advisor working with the MCOs, and the MCO is a healthcare business that contracts with licensed and or certified providers to see Medicaid patients. And so I would work with the MCOs, ensuring that children who I saw receive the care that they needed. Soon after this, however, I was asked to assist the chief medical officer. Again, I wasn't surprised that help would be needed, and it allowed me to be exposed to other parts of medicine. Initially, I was hesitant because I had chosen my specialty for a reason, but as one dear mentor told me, she said, but you started out in general. So, wanting to help and not really being settled, seeing somebody work so hard as a chief medical officer was doing, I absolutely took on that challenge and I started assisting her. Well, she resigned about 4 years after I started, and the position came up. There were individuals who encouraged me to apply for this, And I, again, wondered about this opportunity and my comfort level. But if you remember my picture about never give up, I said, well, why not? However, and I think this is a good thing, I talked to colleagues and I tried to be, I tried to be very careful about what I asked them. And so, and also my husband asked colleagues regarding psychiatrists being the chief medical officer of Medicaid, because now you have to review, advise on you know, all requests for treatment. And it's very interesting. Again, sometimes what we think people believe not necessarily true. And what they told me was, we want somebody who can listen, who will listen to us. We know you can, but who will listen, who'll be logical, and who will make an informed decision and explain that informed decision. And so with that, and my thinking about Medicaid and the purpose of Medicaid. So Medicaid is to fund, reimburse the healthcare cost for some people who have limited income. It's managed, the funds come from the federal government and from the state. And not only did I want to help a part of Medicaid, I wanted to help all of Medicaid patients. And so I did interview, and I was chosen as the chief medical officer in 2016. Well, 2016, I came on board, and it was immediately in the middle of the beginning of a new age of hepatitis C drugs. You know, some even call them miracle drugs. But certainly we were very grateful to have these medications that had far fewer side effects than the previous ones. But they were expensive. And my being in Medicaid at this time in history reminded me of what my colleagues had told me before I even came to Medicaid. You will have to deny medications. And so I struggled with this. For those of you who know, hepatitis is graded on fibrosis score. And in the early years, some states, because the medications were so expensive, required patients to be at a certain fibro score. I will say that Maryland was somewhat fortunate because the previous chief medical officer was a gastroenterologist, and she really championed that we would at least treat by fibrosis 2, F2. It's not great, but it certainly isn't what some states required, and that was they wouldn't treat until a patient was at F3. But it was a really tough time. I would say though that there was a moment when I thought to myself, either you're going to do it or you're not going to do it. And I remember I was at this conference, and we had to do what we call the clinical criteria. You have to say, the clinical criteria of medications is when you define what has to happen in order for a patient to take a medication. And again, remember, I just started this journey 4 years prior. Before that time, I was strictly psychiatry. And I just spent that night, and I just decided I was gonna have to know Hep C. And I just did. And so I started going to Hep C clinics for 6 months. That's what I did. And after that time, I said, you have so many champions. People are just waiting for you to ask for assistance. And I cannot tell you how many people were helpful. Of course, we received the patient's permission for me to be in the clinics. And I learned a lot, not only about the disease process and the medications, but about myself and about other humans being willing to try, with our motivation being helping people. Well, not sooner did I have Hep C under my belt. The opioid overdose epidemic, unfortunately, just really skyrocketed. I want to take a pause here. And I want to show you, I'm showing my little picture of hepatitis C virus. And my pause is because I want to say that sometimes when you are the leader, it's more than just the clinical part. It's also about addressing issues that are challenging to address. And for me at this time, addressing the issue of what is an epidemic was needed. We had populations within Maryland who felt disenfranchised. They felt that there were some neighborhoods, communities who had been suffering from opioid overdoses for decades. And then in 2017, the United States and Maryland would call it an epidemic. And so I had to talk through that with people. And the reason that I did was because what I learned up until this point, being in the rural parts of Maryland, was that sometimes what people really want is for you just to listen to them and to acknowledge that what they say has merit. Now, with that being said, Maryland started prior authorization, and there are positives and negatives to this. Certainly, we had vigorous conversations, and we're still working through that to have a balance. We want people who need opioids to have opioids, and we want people who use them to use them as prescribed. And we want those who are at risk of having an opioid overdose to be evaluated for needing naloxone. Not every patient who takes opioid will be assessed to need naloxone, but certainly we do want all of our prescribers that are right for an opioid to evaluate their patient for needing naloxone. As I moved into my second year, I started to look at other initiatives. And sometimes you find that the way you're doing things aren't necessarily the best way to do things. Again, I was around colleagues and leaders who were so supportive. And because they were supportive, they agreed to reevaluate our policy. And so in some states, the managed care organizations who are charged with managing the care of our patients may be seen by some to not be doing all they can do to make sure our patients are healthy. Not everyone believes that. And I did. I thought that managed care organizations really worked hard to improve the care along with the patient of the individual that was assigned to them. And I'm, again, fortunate that my leaders thought that too. And so there was an old policy that we had, which did not support ensuring that what we call a higher payment for an infant with a very low birth weight was given. And as some of you may know, when a baby is born with a very low birth weight, it can be expensive. And the old thought was, and I'm not saying I agree with this, but the old thought was, well, if we don't give you an extra payment for that second baby, you'll work hard to make sure the mom has a healthy baby. For those of you who know a little bit about very low birth weight, you know that some of us are inherently at risk of having a very low birth weight, more so than others. And then once you have one very low birth weight, by definition, you are at risk of having another. So again, I'm very fortunate. My leaders rethought that. And I will say that the trend is improving. So the part that I really have enjoyed going from being a clinical doc in the office to doing this work, and some of you may have heard this before, is that you get to effect change for populations of people. However, if you remember, I said in government, sometimes you don't have a lot of staff. And I, again, being a child psychiatrist, was working when the Deputy Secretary of the Behavioral Health Administration resigned. And the way that the government is structured in Maryland, if you can see my hands, I can't see you, but you have the governor, and then under the governor, you have the secretary, and we have the Secretary of Health. And under the Secretary of Health, you have various departments. You have the Department of Medicaid, which is CMO, and you have the Department of the Behavioral Health Administration. And by behavioral health, I mean mental health and substance use disorder. Well, that individual resigned. So I thought that it was probably more appropriate for me to volunteer to take the interim position. And the secretary said, great, and I did. Yes, it was challenging. Yes, my husband helped a lot. And yes, I had many sleepless nights. If you think that you have sleepless nights when you're on call. But I would say that I wanted to do it because I felt it was an opportune time to have Medicaid, physical health, and behavioral health work together. We were able to find a deputy secretary in early 2020. I came back to Medicaid and I became the Quality Integrated Care Director. And I was responsible and am responsible for behavioral and physical health initiatives. I'm going to try my best to show you something. I don't know if I'm going to be successful, so I need you to be very, very patient with me. But we, in COVID happened, and when COVID pandemic occurred around the world, I heard from my colleagues, and I heard that we want to talk to our patients. Clinics were closing. We're doing a lot of telehealth. And as we started opening up, we found that people were concerned about vaccinations, and the clinicians, my colleagues, wanted to teach their patients about it, but it was challenging. And so I wanted to help. I talked, well, let me rephrase it. The secretary talked to me, and the secretary said he wanted me to do something. And I talked to the managed care, the Medicaid managed care doctors, the chief medical officers, and we decided to develop a physician support packet. And we got together and we had the secretary sign this letter, and we said, we understand that this has impacted so many people, and we want you to have resources to help you do your job better. So we developed this physician support packet along with our Medical Association of Maryland, and we attached continuing medical education for it. In Maryland, you have to have 50 in 2 years to be licensed. And so if you look at the middle of the screen, you see that the different topics included COVID-19 and associated questions and answers, COVID-19 therapeutics, primary and preventative care, behavioral health access, and suicide risk, social determinants of health. And I don't know if any of you would want to see any of them. Minnie Hill, you'll have to let me know if anybody writes anything in the chat, and I'll show you a particular one. If not, I'll just pick one topic and give you an idea of what I do, because this is what I do now.
Let's do social determinants of health. I think that you just need to share your screen for the other website, because you're only screen sharing your PowerPoint slides.
Oh, really?
Yes, you can do a new share. But
Okay.
I linked the website for our students so that they can see the website as they're going.
Thank you.
Yes.
So how do I do that? How do I do another screen share?
You click new share, the green button,
Mhm.
and then you click on the window.
Okay. Awesome. Thank you.
Of course.
So as Minnie Hill said, I chose the social determinants of health. If you don't mind, let me go back to the very first then. Would that be a good idea?
Yeah, sure. Go ahead.
Okay. So this is what I do now. And this is a letter that was sent by the secretary. And basically what it does is it just introduces to the prescriber that we know you're struggling and we want to help you. And the way that we're going to help you is we're going to give you information so that you don't have to go through pages and pages of information. And so we had experts come together, again, just so fortunate. Experts came together and they consolidated information for prescribers. These from the University of Maryland, from Johns Hopkins, private practitioners. They really came together to help physicians out. And as I was saying before, if you look in the middle of the screen, this is where we have the different topics, and we assigned continuing medical education values to them. It's challenging to find time to look at documents. We know that, but we also know that when you attach CME, I'm more apt to engage in it. So I'll look at social determinants of health. And the reason why this is so important, for those of you who are already familiar with it, please bear with me. From our understanding, anywhere from 30 to 80% of people's health outcomes are related to social determinants of health. And so our prescribers told us that they needed that information and we wanted to give them to them. And so we provided this, the 3 in Maryland, that you can call and receive information for your patient. This document was such that you could rip it out and just give it to your patient. And so do I go back to new share, Minnie Hill?
Yes, so you can click new share again, and you can click on your PowerPoint.
Thank you.
There we go.
And so 2021, the public health emergency continues. And For those of you who are familiar with this, we were in Maryland, at least, we had a difficult time in healthcare to have audio paid for. Immediately throughout the COVID pandemic, the federal government allowed that to occur. In 2022, early this year, the Deputy Secretary of Behavioral Health resigned again, and here I am. So lessons learned, change. What would I have done differently? I didn't tell you this, but my dad, who's wonderful, he encouraged me to take a year off after college. I did do it. I regret that. I needed a break. The other thing I would have changed is after my fellowship, my residency director recommended that I go and take this job as an individual who would develop an inpatient unit. I was concerned that I wasn't ready, and I didn't do it. I should have done it. Why not? Give it a try. I probably, to be really frank with you, would have done it after prayer and meditation, but I think I would have at least wanted to have gone through that process. What I appreciate that I did take a year off after working for a while. I didn't say that before, but I did. It was about a year and a half, 2 years. And then I appreciate that I came to the state, even though I had no strong business or policy or administrative experience. I'm glad I did it anyway. And finally, I appreciate God for the life that he has afforded me. I know that it's a privilege, and I really want to excel, and I want to do good deeds. And with that, I'll end with questions just for you to either think about, you can put in the chat if you want. But what is Medicaid? Just to reiterate, Medicaid is a program that reimburses, funds health care for those with limited income. There's some other criteria, but that's basically it. It is funded by a federal and state. A managed care organization is one which contracts with providers that are licensed or certified to give care to Medicaid patients. And the opioid reversal drug is called naloxone. Now this, I don't know, I don't think I really emphasize this, but it's something that I do want to say because I had a physician who didn't know this in 2022. But naloxone can reverse an overdose from synthetic and natural opioids. So I will end with this statement. If somebody offers you an amazing opportunity, but you are not sure you can do it, say yes, then learn how to do it later. And so when I found this, soon after I came to the state, I offered this to a very dear friend of mine. And 4 years later, she's in a new job and she tells me I take this with me. And so I give that to you. If it speaks to you, great. And if it doesn't, please take what speaks to you because you have so much to offer and so much to give. And I thank you so much for giving me your Saturday. And so with that, I will turn it over to Minnie.
Thank you so much, Dr. Burgess. We really appreciate your time and teaching us and mentoring us. I really appreciate that quote at the end as well. I know that a couple of the students who work on the team with us, they're just like that. When you offer opportunities for others, you should say yes and go for it and learn later how to do it. So now we'll be transitioning into our Q&A session. We have a couple of questions for you, if that's okay with you. I think just 5 or 6 that popped up in the chat box. So we'll have one of our interns take it away.
Thank you for your mentorship and teaching, Dr. Burgess. We'll now begin our Q&A session. My name is Hamza Ahmed. I'm in a BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine. So to start off our Q&A, what has been your greatest challenges as one of your greatest challenges as a clinician working with people in a non-clinical background in policy and government?
What is my greatest challenge working with non-clinical people?
Yes, in government.
I would say my greatest challenge, my greatest learning opportunity is being patient and understanding that sometimes people really don't know. And I presume they know. And because we learn in such a graduated fashion that it's almost like second nature, the information that we learn. There are some people who really don't know. And even when I'm doing a project, like when I was doing Hep C, and I'm thinking, because I'm reading all the time, and you're the budget guy that can say, yes, we're not going to have many, then obviously you know what I know. And I was on a call, and we call them Department of Budget and Management, and they wouldn't give us this money for Hep C drugs. And we were talking, and you get real quiet and just listen to yourself. And I thought, I wonder if he understands that this is like the standard of care. And I said, you do understand this is standard of care? And he said, no. And so my biggest challenge is being patient with people, because after I said, this is the standard of care, and the American Association of the Study of Liver Diseases say that we should be treating all patients with Hep C, they gave us the money. Literally, it was that easy. And so had I thought, you're just not being cooperative, you just don't care about these patients, and not said that one sentence, I don't know if we would have had that money. So I think for me, that's my biggest challenge, is myself. Thank you for asking me. I had not thought about that for a while, so I thank you for that question.
All right. Thank you very much for the answer. What is the difference between an acting deputy secretary and a non-interim deputy secretary?
Excellent question. That's an excellent question. And many of us don't get it right. So an acting deputy secretary, acting anything, is basically someone who's taking the position when the person that leaves is coming back. So for example, if someone goes for a sabbatical, if someone goes for family leave, that would be an acting. An interim office, interim deputy secretary, is someone who comes into a position when the person that left isn't coming back. Thank you for that question.
Thank you very much for that question, answer as well. What are a couple of accomplishments within the DHA or Medicaid that you're most proud of?
I'll be frank with you. I would say the changing the policy for the very low birth weight. And I'll tell you why. When you're in government and you don't have positional power, you really, if you really want to affect change, it's really relationships. And I really didn't do much of that building when I was younger, because I was, you make the grades and that's really what's required of you. But I would say that the knowledge that I was missing out on that allowed me to develop that competence. And so with a very low birth weight, I had to go and find out what we call the unofficial leader. And you identify that person who may not have the title, but was really calling the shots. And then find out if that person would support it. And then when you go to say, oh, I want to recommend this, the answer is going to be yes, because the unofficial leader already told you that they would agree. And so the fact that we changed this policy that impacted women who were vulnerable was huge. And again, the fact that we're seeing trends that they're improving, I'm very happy with that.
Right. Thank you very much for that answer as well. How did you fully transition your previous patients in your clinical practice when you started working for the state full time?
Great question. Hill, I feel like my screen is going dull. Can you tell if it's dull?
No, we can see you perfectly.
So emotionally it was hard, for sure. Practically, I gave my office maybe 6 months or more notice. And that was challenging because the people said, my new boss, why would you need 6 months? And I think they called my office and found out that really your waiting list is about 6 months with the child psychiatrist. And so it was hard to transition because of the reason that I left, and I want them to have excellent care. But I did, and we found other clinicians to see them. I worked with a pharmacist in town because we knew each other, to make sure that all my patients had their prescriptions way down the line. And remember, I was going to be the Medicaid advisor. So some of my patients had Medicaid, and so if they had any difficulties, I was the one that they would come to anyway. But they didn't. We really worked hard together to make sure that the patients were cared for. And so having that time was really key. Talking to parents about what to do, talking to schools, prepping them, preparing them for saying bye was very important. And with that, and support of my staff and the parents, we made the transition. It was hard, even for the adults, because I was seeing adults and children. It was hard. Even today, I remember that. But that's what I did. I did it anyway. Thank you.
Thank you very much for that answer as well. Given you wear several hats in government, how do you manage your work-life balance?
Well, I laugh a lot, but not the giddy laugh, but the robust, grateful, because it doesn't have to be this way, right? It could be that no one wants you. It could be they don't want you to work for them. That's another way to look at it. But on a serious note, I fight for it. I work until about 6 for sure, and longer at times. For you who do rotations, sometimes you have some very long nights and overnights, and I still do, even at my age. And but I carve it out. I figure if I'm not the president of the United States, then I can figure out time for myself too. That's how I do it. And you can too. And you know what? You'll become more efficient. You'll prioritize better. You will surround yourself. You will be laser focused on surrounding yourself with good people. Hill there, right? You'll make sure that they're passionate, that they want to work, and that's why I hire somebody who wants to work just like I do. And people who are good spirited. If any of you are around individuals who are like that, that if anything, you have more energy, not less. And I do encourage you, exercise, eat well, because even though I don't feel like eating sometimes, I make myself eat. And what I do eat, I make it count. I mean, I eat chips too. I mean, don't get me wrong, but I really do try to focus on understanding that if I have a schedule, if I'm not going to sleep a lot, you've got to feed your body. And to be really frank with you, if I may say this, I pray. And I fight for my prayer time. I fight for my meditation time. And if I may say this, not to offend anybody, but I fight for my scripture reading So I carve out that, and you think, well, that's 3 hours. How you gonna do that? But it's amazing when you do that, you become again more focused, more efficient, and more effective. I do far better when and I don't always do it. So I want to be transparent. But more times than not, you'll find that's what I'm doing. Thank you.
Thank you very much, Dr. Burgess. I agree, eating well and living a healthy lifestyle and praying helps us stay the best for our future patients. So for our last question, reflecting back on your journey, what has been your favorite part of your career thus far?
What I'm doing now, that's my favorite part. The people I meet. I was talking to a mentor, and he said, "Do you know how much you've grown? I mean, do you?" And you sometimes you can't tell the people I meet doing good deeds, and looking back and knowing that I said yes. And so it's what I'm doing right now. Doing integrated care is something I'm passionate about, and quite frankly, finding time to talk to you. This is a privilege, and I thank you so much for asking me to do it.
Thank you, Dr. Burgess, for coming on here and speaking to us. And these are all the questions we had for today.
Very good.
And thank you. Thank you very much, Dr. Burgess. I really appreciate you taking all the time to answer our questions and taking the time out of your busy schedule and day to mentor us. And I love everyone to please give a warm thank you to Dr. Burgess in the chat box for this incredibly informative session. Thank you.
Thank you. Have a wonderful day.
Thank you.
Bye-bye.
All right, now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live, and you will need a 70% or higher to pass and receive certification for the session. And that link will be sent in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next TeleShadowing session will be next Saturday, August 20th at 10 a.m. Eastern Standard Time with our physician mentoring us in internal medicine. And please be sure to note that the session after that week will be at 12 p.m. EST instead of 10 a.m. So this concludes this week's shadowing session, and I hope to see you in upcoming sessions as well. And thank you.